Welcome to Patient Voice. Our theme today is on different abilities. This is brought to you by the Office of Health Equity and Inclusion. We are exploring access and inclusion in the healthcare system today and hope to provide practical knowledge and skills for healthcare providers through our panel and discussion. This panel is sponsored in part by the College of Health, Department of Nutrition and Integrative Physiology. We have learning objectives today. The first thing that we want to accomplish is distinguishing between access and inclusion in the healthcare system. They're different words, and so we're going to be talking about definitions and also talking about what they look like in action. Second, we're interested in developing practical knowledge and skills to partner with patients with different abilities. And lastly, develop understanding of effective techniques to communicate across difference. And there are CMEs available for this session. There's a sign-in sheet if you missed it up front. These are our learning objectives for today. So our operating definitions. It's always nice to set an operating definition for a conversation so we have kind of a shared place of understanding. And so on the NCBI site, they define access as the opportunity to identify healthcare needs, to seek healthcare services, to reach, to obtain, to use healthcare services, and to actually have the need for services fulfilled. And then there are dimensions of accessibility, such as approachability, acceptability, availability and accommodation, affordability and appropriateness, as well as 5 corresponding abilities of populations. Ability to perceive, ability to seek, ability to reach, ability to pay, ability to engage. So access. Inclusion defined all people, regardless of their abilities, disabilities, or healthcare needs, have the right to be respected and appreciated as valuable members of their community and of our larger communities as a whole. So this is our working definitions for today. A little bit about me. My name is Sarah Elizabeth Levitt. I'm the Associate Director of the Department of Nutrition and Integrative Physiology. What that looks like daily is I administratively manage our Academic Affairs Unit and the Public Service Center, the Utah Center for Community Nutrition. Utah Center for Community Nutrition. This topic is very close to my heart. I also have an appointment at the Huntsman Cancer Institute as a cancer fitness instructor. My modalities are yoga and qigong, and I look at those modalities from a different ability perspective as part of healing and health, and looking at the whole person. Up in the top, that was my recent presentation in Orlando around yoga therapy for non-pharmacologic pain management. Then below is me and my role, and then, of course, highlighted, most important, is my big brother, John, who has Down syndrome, and my mother, who passed away about 1.5 years ago. Both had different abilities. Both I was an advocate for, and still am. My brother John has had 3 occurrences of leukemia. Luckily, he's in remission right now, so he's doing really well. He just had a birthday, and we had ice cream. It was awesome. We wanted to go for ice cream, that's where we went. And then my mother, who later in life had a lot of health complications and ultimately was physically disabled, lost her sight to diabetic retinopathy, had dementia, and then lastly, endometrial cancer. And boy, if she heard me say it that way, I know what she'd say. She'd be like, Sarah Elizabeth, sounds so awful when you say it like that. and I'm like, because that's not who she was as a person, and that's not who she is to me in my heart, right? So definitely passionate about access and inclusion and redefining what it means to live a life fulfilled and to experience quality of life and to support one another in high quality of life. I am so thrilled to work with Lisa Maurice. We've been colleagues for a while. She's an inspiration. She is a national and international expert in patient advocacy and serves on many national committees in this regard. It's quite a coup to have her here moderating our panel. So with that, I will hand it off to Lisa Maurice.
I'm so honored to be here today. I actually started out my career as a broadcaster and was just really enjoying that when I decided to take a little hiccup and have children. The first child I had was 9 weeks early and came home on oxygen, and I was carting an oxygen tank with me everywhere that I went. The second child that I had 18 months later started screaming upon arrival and did not stop, literally, for 9 months except for when sleeping, and later was diagnosed with an autism spectrum disorder. My third child, boy, you'd think things would get better, right? Was born unable to breathe or swallow, and he is here today. Skylar spent a large part of his childhood with tracheotomy, and on and off has had to be tube fed because of craniofacial issues that impacted the ability to swallow. So as a caregiver, I had the opportunity to be lugging 3 toddlers at one point, 1 oxygen tank, a pulse oximeter, a feeding pump, and other stuff along with, diapers. On my shoulder while pushing the kiddos in the stroller, it was just really an exciting experience in testing accessibility, trust me. I decided to go into advocacy, first locally and then nationally, because quality and safety are very important to me. How about you? Quality and safety, right? Part of quality and safety is inclusion and access. Let's see. Oops, I guess we go the other direction. There we go. We have 5 amazing individuals, and I'm not saying that just because Skylar is one of them. 5 amazing people who are joining us today who have taken their experiences in life and used them to advocate for all of us. And we want them to introduce themselves as well. And let's go from left to right. Well, actually, I guess we'll go we'll go left to right because the slides would show something else. So let's start with Andrew, please.
I'm Andrew Regal, and I'm the public policy advocate for the Disability Law Center.
I think you're supposed to do more of an intro than that.
Yeah. Is this the whole?
Tell us just a little bit about yourself.
So, let's see. About myself. I have. So I grew up and went to school here, and escaped for about a decade to go to undergrad and grad school, and then got sucked back in, and have spent the 15 years since trying to figure out how to escape again. So if anybody has any tips or tricks, let me know. This is not it. This was taken at a family reunion a couple weeks ago near Monterey. Funny story about beach chairs is the first time I encountered one of these things was on Maui, and nobody told us that they were beach chairs, meaning they are not ocean chairs. We took it in the water, not accounting for the waves, and that it would also try to float away at the same time. So it was a really good thing that there were 4 people with me, and if we become Facebook friends, there's some really good video of me as a cork, and that's kind of fun to watch occasionally. So, and then the other thing, I don't know if you all are aware of this, but the rehabilitation folks here and the School of Engineering folks have a collaboration in which the physical rehab folks in the School of Engineering have a collaboration in which they develop equipment that folks with different types of disabilities can use to access the outdoors and different kinds of sports and stuff. So they have developed a catamaran pontoon sailboat that you can control with a joystick, just like the one I have on the chair. And so I've recently been able to discover sailing. So I'm really excited about that. They're trying to convince me, because they have a similar setup that they use for in a toboggan for skiing. So they're trying to convince me to do that, but I really am strongly opposed to cold, and also falling over in face full of snow. So
it sounds like you've got some really great examples of access and inclusion.
And a lot of good stuff is happening here. So
absolutely. Let's have a quick introduction by Stacy.
Yeah, I'm Stacy Stanford. I'm the policy analyst at the Utah Health Policy Project. I was in a car accident 8 years ago, which really quickly caused my health to unravel and triggered some neurological issues. And right at the time when my health was deteriorating the most, I lost my job and lost my health insurance. And so I fell into what is known as the Medicaid coverage gap, because in Utah, in order to qualify for Medicaid, it's not enough to be poor. You have to be technically counted as disabled, which is a real narrow eligibility category. And so even though I was using a wheelchair and nearly bedridden and very, very sick, I did not qualify for Medicaid. And so that led to a lot of advocacy, because I knew that I wasn't alone, and got involved in Medicaid expansion and healthcare advocacy from a disability rights perspective. I studied disability justice at Westminster College. It was a customized degree program. I got to design my curriculum around my interests, and then started working full-time at UHPP pretty much immediately upon graduation.
UHPP is?
Utah Health Policy Project. And now I'm heavily involved in the Proposition 3 campaign that would expand Medicaid. So I have 6 more days working on that. And then I change gears to all kinds of other healthcare access and disability rights issues.
Thank you for your advocacy. That's really admirable. And remember, one of the A's in inclusion was affordability and being able to access based on cost. So, number 3, Stephanie, would you share a little bit about you, please?
Sure. So my name is Stephanie, and I am a community advocate for individuals with traumatic brain injuries. I was in a surfing accident in 2015, and a surfboard smashed me in my face, and so I kind of had to relearn quite a few aspects of life. It's kind of similar to Stacy's story. While I was in the hospital trying to recover and in treatment, recognizing I wasn't going to be able to get back to work, I was literally learning to talk and walk again. So my employer had to let me go, and I lost my employer-based health insurance, and I was unable to access health care. A little different, so my story is I'm fortunate to have been able, it sounds weird to say you're fortunate to be able to be labeled by the federal government as disabled, and I was able to access the label and have the disability benefits, but State of Utah actually still continued to deny me health insurance through Medicaid for 17 months. And I, similar to Stacy, the experience really had me want to get more involved in healthcare advocacy, and then with traumatic brain injury survivors, they're overly represented in the criminal justice system, and there's many ways where their ability to go through life is, they're not always given the amount of respect that they deserve. So I try to do some advocacy in that, and mostly I just follow around several of the people at this table, and just I just call myself their fan. So I just do a little bit of legislative.
Well, we're glad, Stephanie, that you followed them here.
And Stephanie is severely underselling what she does. If you've been following any media lately or listening to the radio or anything like that, so.
Thanks for that sharing that. Okay, Ginger. Your
Hi.
turn.
Okay. Hi, my name is Ginger Phillips, and I am a certified peer support specialist. I also actually was the peer support trainer since peer support came to Utah in 2010. Sorry, I need to take out my gun. Sorry about that, guys. Anyway, I was the peer support trainer for 7 years. Now I am the suicide prevention state trainer. I also teach people how to be advocates, mainly legislative advocates. And I also work with a woman named Regal who teaches with me on trauma-informed care. She was the 65th wife of Warren Jeffs. And so we have trainings quite often all together. So if any of you are interested, we're opening it up to all. Just let me know. Let's see, I am an advocate, pretty outspoken. So maybe one of the most outspoken in the state of Utah when it comes to mental illness. I'm always up at the legislature. I live up there, pretty much. I always say I have to take extra antipsychotics to even be there, but whatever, so, anyway, but I guess I just wanted to say that I am not just an advocate. I feel like that's all I focus on. I think I'm a whole person, and I try to support my peers who are living with mental illness and make sure they have a voice. But I'm also a sister, I'm an aunt, I'm a great aunt, and I'm a daughter, granddaughter, so I just wanted to make sure all of you knew that that's me. The mental illness is on the side. I have been diagnosed with schizophrenia, but I don't go around I don't care if anyone knows, but I don't go around and say, hey, I'm Ginger, I'm a schizophrenic, so I'm someone who's living with it, and yeah, I guess that's all about me.
Thanks so much, Ginger. Skylar.
I'm Skylar. I'm 25. I was born and raised in Salt Lake City, Utah. And right now, I'm a biomedical informatics student in the University of Utah. One of my professors is here. And I studied social work at Utah State University. And I was born with a rare birth defect called Pierre-Robin sequence. And it's a triad of anomalies. You have micronanthia, which is a small jaw, and glossoptosis, which is a tongue that leans back, and then you also have a cleft palate, and I don't know the medical term for that, but it's just cleft palate. And because of that birth defect, I wasn't rescued properly at birth, and I have a brain injury. So due to that brain injury, I have upper trunk cerebral palsy, and I also have a learning disability where I only can recall 10% of what I read. And there are a lot of other things that go along with that brain injury, but those are what I will be focusing on today. And I just have a lot of diverse exposure to healthcare. I've been, Lisa was talking about yesterday that I've been to an ER, I've been to oncology because my cousin had cancer, I've been to radiology, I've been to OT, I've just been lots of places. And access to me means that your healthcare provider, even though they can't be everywhere at once, at least takes the time to talk to you about what's important to you, and at least keeps a note of that in the EHR or remembers that so that your needs are being met, not just medically, but also in terms of what you need socially and what you need to have assurance that you feel safe.
That's great. Thank you so much. And we'll circle back around to that. Andrew, would you share with us now your perspective on access and inclusion?
With this group, I consider myself very lucky, because other than the disability itself, I am one of the healthiest people I know, which for me, fortunately, has meant that basically the only time I ever see a doc is when I need them to sign a prescription for new batteries or new tires for the chair. Why a doc is expected to have any expertise on whether I need new batteries or new tires, I don't know. That's another conversation we should have in another time. But fortunately, that's basically the only time I've had to see a doc in a quasi-medical context. However, I just wanted to mention two experiences that I've had. One is when, because I haven't needed to see a physician very often. I've never really thought much about having a consistent primary care provider. And with the passage of the ACA in 2010 and the coverage for annual physicals, I thought, and getting older, which we won't talk about, I thought maybe now it would be a good idea to start acting somewhat like a grown-up and go get a physical to make sure that everything is generally okay and there's nothing to worry about general overall health-wise. So I thought, well, who would be a good person to go to? And I thought a physiatrist would be a decent first step, because if you know anything about physiatry, they are MDs who are specifically trained to work with patients who have disabilities. So I thought, well, that seems to be a decent combination. Let's see how that goes. So I went to the physiatrist, and she did the usual disability things, range of motion, checking this and that, and saying, you might want to do a little bit more of this, a little bit less of that, and so that you can maintain as much functionality as you can. The stuff I've been used to hearing over the years. And so we get to the end of the appointment, and I ask her two things. I say, so I've got this mole on my thigh that seems to have changed color and maybe shape and maybe size over time. You think it's anything I should be concerned about? And I also say, so, should we do a stress test? Are there any blood tests that we should run? Should I be worried about cholesterol? All that stuff. And she's like, oh yeah, maybe that's a thing. So she goes out, and they send me down to the lab, and they stick the finger and run the usual test, but only because I mentioned it. And she looked at the mole and she said, "Oh, let's keep an eye on it. Doesn't look like it's anything to worry about, but let's keep an eye on it." A couple months ago, I tagged along with my dad to an appointment to a dermatologist, and my dad said at the end of his appointment, "Hey, would you mind looking in at this mole on Andrew's thigh and telling us what you think?" He looked at it and said, "Yeah, I think we might want to get this. We might want to get this biopsy." And it turned out that it was early stage melanoma. And my experience with that is that a general practice doc is good at general practice stuff. Not so great at disability related stuff, just because they don't see it very often. But if you end up going to a disability doc, they'll be pretty good at the disability stuff and be able to tell you a lot about that. But general health stuff, not so great. And so for me, it felt like I was kind of caught in the middle.
That's a tough feeling to have,
Yeah.
for sure. And I really appreciate you sharing that, because we certainly have had similar experiences where people didn't look at our whole self.
Yeah.
Absolutely.
Exactly.
So let's move on and see what Ginger has to share about access and inclusion. We're trying to get
Can you
everybody.
show them the first screen so they can get my contact info?
Absolutely.
Here you guys go. Here's my contact info. Feel free to contact me. Anyway, I'm here if you have any questions or whatever. So, anyway, I was going to show you the picture that this is some of the advocacy I've done up there in the corner. I was speaking in Washington, D.C. in August. We did some whatever thing with the governor, and that's me talking up at the legislature with Representative Rudd. Okay, there we go. All right. So I guess the main thing, talking about the whole person, I guess I'll just talk about that since she brought it up. I guess the whole person to me is actually considering, and that it's kind of in collaboration with person-centered care. If y'all know what that is, I'm sure you do. So person-centered care and being in collaboration with my physical doctor as well as my mental health doctor, or any other providers that I may seek out, that they're all in collaboration, including my therapist. Yeah, and I even have a dietitian. Like, I make sure that everyone is connected now. I know before, I do want to mention the top bullet point, which is not feeling stigmatized. And I think that for a very long time, I felt like with doctors in, in a physical health way, I thought they wouldn't understand me because my mental health record is huge. So, you could probably find a stack of my mental health record. And so that to me, since I changed over time, that to me was scary. But I have found, I see a doctor over at the Madsen Clinic, and I have found she's amazing. She understands mental health, and I think that doctors are really trying, or whatever field that you're in the health sciences. I believe my main goal is actually to be a voice for myself, so that I can be part of that person-centered care where I can help the doctor in creating a plan for me. And that's, once again, in a collaboration with me and the doctor. You know, it's not just doctor upon doctor, collaboration between them. It's me and the doctor and the other people. So, and as part of the whole health, I think that there is more surrounding whole health that people just are not getting. But it's not the fault of the people out there. It's for us to teach, right? It's for people with, a disability. If someone doesn't understand, tell them. That's my thing. Probably some of my doctors are probably like, okay, stop telling me, we're like, because I talk a lot. I'm pretty straightforward. I'll say what needs to be said. And I think that in the last several years, it's been a lot better because I'm working in collaboration with them. And I just want to also mention that with whole health, there are 10 domains that I always talk about with my peers. That, it doesn't just have to do with physical and mental health, but it has to do with like sleep and eating and physical activity. I don't like exercise, physical activity, just like those kind of things. Spiritual, service to other, having a support group. And I just always like to touch on that because I think that is what has helped my peers the most. Not just the trainings I provide, but that.
I really want to reflect quickly on what you said, Ginger, because how many of you are familiar with the concept of the medical home? So ideally, in a practice, the medical home would coordinate all those aspects that Ginger says she is now coordinating. And if a practice is going to be certified as a medical home by NCQA, the National Committee on Quality Assurance, there's certain guidelines that they need to meet. And one of them is helping coordinate care. So thank you so much, Ginger, for sharing that. Skylar, you're up.
All right, first I have to explain, so there's a picture of a Pikachu and medical equipment there, because I feel, at least from a pediatric standpoint, that is a good representation of access and inclusion. And Pikachu died. It's live again. Okay, when I was little, I just was afraid of surgery for the first time, and it was like my 15th, so why would I be? But the child life made up that Pikachu so that I wasn't afraid anymore, so I like showing that picture. But anyway, how many of you, this is an obvious question, I like asking those, but how many of you have internet access?
Me.
Yay, that means you don't have first world problems. So I'm sure you guys wouldn't appreciate it if an internet provider or a bank said you have to get internet access that covers this section of the town you live in, but it doesn't have Wi-Fi where you live. That's not giving you access to internet that meets your needs. Similar things happen in healthcare, where doctors ask you to do things that don't cover the domain of what you're comfortable with or what you can achieve. So to me, access means having things available according to my needs, not the doctor's needs, not insurance's needs, not the hospital's needs, but my needs. And sometimes if meeting my needs 100% isn't possible, you can collaborate and find ways with social workers or other people to come up with an alternative solution. A good example of this with access for me is when I was in college 2 years ago, I was undergoing medical treatment for something, and I had to read this like 70-page document that outlined the different parameters of that treatment. And I went to my provider and said, there's no way I'm going to be able to read all of this because I can't remember it. But if you explain it to me for 5 minutes, I'll understand it all. And he did, and he even called my psychologist to say, will he be able to understand what I'm saying if you can't read it? And she was like, yes. And that was a good example of access to me because I got access to the information I needed in a way that my needs had to be met. And inclusion to me is kind of like what Ginger said. It's being seen as a person beyond what you experience. When I was a child in the hospital, one thing they would do with child life is they would ask for information like, what's your pet's name? What is your favorite color? What's your favorite place to go? What's your favorite subject in school? And they would post that in your room. So you would be seen holistically as a person beyond just, oh, Skylar, the tricked kid in a hospital bed. So that's important. Also, the other end of that is being labeled as someone with a disability on your own terms. I worked at a outdoor adventure facility for people with disabilities for my social work practicum, and a lot of people didn't want to be referred to by their diagnosis because they wanted to be seen with their disability on their own terms. Even if they have a disability, you address the disability in a way they prefer.
Thank you so much. We are running out of time, and I want to get to Stacy and Stephanie, so let's
Yeah, so for access and inclusion both, I think that from my perspective through the disability rights lens, it's very important to widen the umbrella of disability and what we consider as disabled when we're thinking about access and inclusion, and especially creating policies that help the disabled population. You have to think much broader than, like we mentioned before, the government definition of disability definitely doesn't go far enough, right? But even the common thoughts that people have when they think of disability often doesn't go far enough. We often exclude people with mental health conditions, people with substance use disorder, survivors of violence, survivors of sexual violence, veterans. If we really want to create wide, inclusive policy and think broadly in including disabled people and creating access, you have to really open up that umbrella of what might count as disabled. And that's where you really can create meaningful accommodations, is if you think past what might come to mind. You might think wheelchair and crutches, or you might think hearing aids and glasses, so really broadening that vision so that you can expand your definition of disability and therefore expand your definition of accessibility and accommodation and inclusion. And one of the ways that you can do that is in recognizing, as has been said here quite a bit, that access is very individual, and that you might see 10 patients who are autistic, and those autistic patients might have 10 different total sets of needs and accommodations that they need. You might see 10 different wheelchair users who Andrew and I both use a wheelchair, and we have very different experiences. I have chronic pain, I have illnesses, and Andrew needs it to get around, but it's a different experience of lived disability. Even if we had the same rig, we would experience it differently. And so you have to really consider the individual, and that requires a great deal of flexibility. I did my thesis research on healthcare access for autistic adults, and the recommendations that came back from the autistic patients. I asked about negative experiences, but also asked about what would your ideal doctor appointment look like? What would your ideal medical visit look like? And it was all very unique. I would like a private waiting room. I would like my materials in writing. I don't want any materials in writing, and I want the doctor to explain it to me. So huge different variations of what an ideal doctor appointment looks like, of what accessibility and accommodation looks like.
I think that is such an important point, Stacy. I know one time when Skylar had surgery, they were, the physician had another patient that had the same surgery and wanted to treat the two patients the same, even though they had surgery for the same surgery but for different reasons, and that did not work out well. That's another story. I'm sorry, we do need to move along.
No, that's fine.
So I recently was asked to help kind of guide some peer review efforts on some research done with individuals with traumatic brain injuries, and something that really stuck out to me while I was reading this research was that communication is one of the biggest barriers. If you take all traumatic brain injury survivors, most of them are going to have some element of communication disorder, and sometimes it's the motor skills, the articulation of our words, but sometimes it's the organization of words. So initially it was like motor development for me, but now it's just really hard for me to organize information and be efficient in the way I communicate. And because of that, it requires a lot of active listening to find my point, especially in the healthcare world. I have 4 or 5 appointments a week in ongoing treatment, and I'm really grateful for that treatment. Not having it for a long time was an incredible barrier, but sometimes it's a barrier to get to the appointments. I won't ever drive again, and the public transportation and just like how much time I spend to get there, setting up the appointment can be really difficult because I can't remember what the message said at the beginning of the phone call saying press this number for this. Setting up an appointment can be a terrible experience. And so there's all these barriers that may exist just for me to get to the appointment. And then if I'm there and I really need to discuss something or I really want to achieve something and I have no idea how to explain it or articulate myself, or if I try really hard and then my point is misunderstood, I feel so much frustration because that was my whole day. And thankfully I have got really great medical providers who typically are able to engage in active listening and repeat back to me what I've said to make sure that we're on the same page. And many of their office staff understand the population they're working with, and they've been able to work with people who have a hard time getting the appointment set up. And there is this joke that like when you're inpatient in a hospital on like the neurotrauma floor, I mean, like everything is terrible for your brain. Like nothing there. I mean, the lights, the noise, they're interrupting you while you're sleeping, ask you the same questions all the time. You can't remember, especially if you're trying to learn to talk again, and it can be really frustrating. But we maybe can't solve like all of those, but I think there are ways where, whether it's active listening or just really staying engaged in the patient to make sure that they feel like they were heard and that what they came there, that they can walk away feeling like it was, that the sacrifices that they may have made to be able to be there are worth it to them. And I think that's just been something that I've found often.
I think those are really valuable insights, don't you? Let's give them a round of applause. We're going to run through a couple of other slides and then we'll take 2 questions. These are the resources. How many of you are from the Office of Health Equity and Inclusion? That's great. I did want to mention that I work a lot with Partnerships for Patients, and we have a health equity set of guidelines, and the University of Utah is a Vizient member of the Partnership for Patients, and they have some great resources that they told me to tell you, give them a call because they want to share. So, questions and answers. What questions do you have? Time for about 2. Yes?
So first of all, thank you all for coming. We are so grateful that you've shared your experience. And I got to tell you that every time we talk about this, I think people are uncomfortable speaking about this, and your bravery is just beautiful. Thank you. So now that I've said that, I have a question that's a little bit harder to answer, but I would love for you to dispel a myth for me. And that is, my primary identity is that I'm a family doc. So I think one of you gets seen at Madsen. I hope it's by one of our residents or attendings, so I can go back and tell them what a great job they're doing.
Dr. Frank.
Oh yes,
Frank.
she's our associate residency program director.
Yep.
So I will tell her.
Please.
So good, I'm glad that we're doing a good job over there with family medicine. The issue that I want to talk about has to do with the whole problem that people misperceive. And that has to do with how the government supports people with different abilities. And I'll tell you the misperception that comes into my office all the time. And that is that people tell me that, oh, this is going to be great because now I'm going to be able to, it's not, my patients have never said this, but they say that people tell them that, why are you trying to do this because you're gonna be a leech on the system and all this terrible negative stuff. And when I hear it from my patients, I say you need to ignore them. As far as I'm concerned, if any of my tax money goes to help you, that's a good investment.
Yeah.
Because we've seen how that money gets wasted.
So let me
So
see
my
if we
question
can
is-
unpack this. Your question is what they have experienced in terms of their access to services.
To benefits specifically.
To benefits, okay, or services. So let's go down the line. Andrew, if you would just in about 20 seconds say what kinds of supports you receive.
I'm fortunate in that because I have a visible disability that's not hard to document, that has very specific needs attached to it, that I have not had trouble accessing benefits in terms of services. What I use are personal care services in the morning and in the evening. That can be more of a challenge, just working with home health agencies and finding and hiring people and getting folks there and dealing with turnover. But comparatively speaking, my experience has been relatively smooth.
I think speaking more broadly, you're seeing the myth of, well, if you're disabled, you must qualify for all kind of help. That's what you're hearing, right? And I think people tell themselves that so they can sleep better at night. They don't want to look at me when I was sick and bedridden and think nobody's helping her. That's not a fun thought to have. People look at me and think, oh, somebody must be helping her. That's what I heard from the legislators. Well, there must be a free clinic. There must be a doctor who will donate. There must be something. And what you have to understand is that the system is not designed with a welcome mat to bring in all the disabled people and help them all and give them all benefits. The system is designed to weed out. The system is exclusionary. I don't qualify for anything. I get zero assistance from the government. When I was at my sickest, my most desperate, I got zero assistance from the government. I finally got access to health care through a part-time job. By getting access to health care, my health improved, believe it or not. And so now I work full-time and I buy my own insurance. I don't have access to anything. And that's very, very common, especially with mental illness, with chronic illness, invisible disability. You have to understand the system is not designed to cradle those of us who need help. It's designed to keep out thousands and thousands of people who need help. That's the myth that you're encountering.
Absolutely.
And it's a government failure. They
Exactly.
Okay,
Exactly. Thank you.
So I was able to get disability benefits. I don't remember the timeline. My brother manages all of this in my life, but I do know that after receiving monthly disability benefits, and it's not a lot. I don't know the exact number, but I know I have to pay $160-ish down every month just to qualify for Medicaid in Utah. So even though the federal government, so it really is a mess and very difficult, requires sometimes 15 to 20 hours a month of trying to get everybody on the same page, and they regularly disenroll me from Medicaid, almost monthly sometimes. So there are a lot of myths out there, and I think everybody's experience is probably so different as far as where do they hit the barriers. But yeah, everything Stacy said, the complex enrollment policies are set up to prevent individuals from being able to access health insurance and other benefits. So it's a mess.
Okay, so I have been on SSDI for a really long time, and I also paid into the system for many, many years.
Social Security Disability Income.
Yep, sorry, thanks. I always forget about that. Okay, I also have Medicare and Medicaid. I've also been on that for a while because I qualify for SSDI. I have Medicare, and because of Medicare is my primary, it pays for my meds, which a lot of people with mental illness do not have access to. Super expensive meds. My doctors are paid for. The psychiatric unit is paid for. Uni, that's the only unit I will go to because I hate every other hospital, it seems like. But Uni takes good care of me. And so, and I have case management. Also, there are benefit specialists in the state for people who need help with benefits. I know quite a bit for someone who's been on disability, because I taught this to my peers. Once you start teaching it, it's oh, I guess I gotta know it because I'm teaching it, right? So anyway, that's what I get.
Okay, Skylar?
I don't This is just my belief about my life personally. It's not saying anything about anybody else, but I don't think it's anyone's business whether or not I receive help from the government. And if you want to know what government aid I qualify for, you can look at education standards, because that's, but, yeah, no comment.
Well, thanks for sharing that. And thank you for dispelling that myth. It bothers me that is out in the community. And I sign those papers every single day because nobody makes this stuff
So,
up.
and I would point out
Thank
also,
you.
and I really appreciate that question, I would point out that as I work nationally, every state is different. Every state is totally different. And if you have a hard time because you have a disability navigating Smiths or whatever, how in heaven's name do you navigate the paperwork and other things that are involved with getting a disability declaration and receiving services? It's mind-boggling. And you have a question. That's going to be our last question.
Okay. So being an academic institution, many of us are involved in training future healthcare providers. So my question to you all is, and I know this is reductive, but what's your opinion on how we can better train future healthcare providers to provide better, more inclusive care?
Don't everybody answer at once. Let's start with Skylar and go the other direction.
First, you need to give them a lot of exposure to different kinds of patients, not in the textbook, but in person. And second, you need to let them know themselves better, so they know what their limits are in healthcare, so that they don't have unrealistic expectations of themselves, and that way they don't feel comfortable in certain situations that they don't want to put themselves in. And
Okay, that's
yeah.
your time.
Okay, so this is easy. Okay, I would have a person come and talk to you, especially someone with mental illness. A lot of people think, oh, they might not be able to articulate, but I would have someone come talk while you're training. And the other thing I would say is to seek out someone who has a peer support thing, because they've been taught to tell their story.
Stephanie?
I would say teach them to believe their patients and trust their patients.
Amen.
We know our bodies.
Yeah, I was very close to that. Just don't be afraid of disability. If you encounter somebody that thinks differently, somebody that looks differently, it's okay to be uncomfortable and recognize that discomfort is a normal human thing, but then talk to your patient. No, don't be afraid of not knowing things. You might not know, believe it or not, sometimes your patient really does know their body better than you do. And you need to ask them about what they're experiencing, and you need to believe them when they tell you. And ask your peers too. It's okay to not know things as a doctor.
Andrew?
Two things. One, very, very quickly on the previous question and comment, and that is that something that a lot of folks miss is that Medicaid provides a whole range of services that aren't available anywhere else. If you don't have Medicaid, nobody else pays for long-term care. Nobody else pays for intensive mental health treatment. So that's, besides being a low-income program, it provides all kinds of services and supports that aren't available anywhere else. And if you need them, it's the only option. So, to your question, my advice, I think, from my own experience as well as reflecting what's been said here today, is break down silos between general medicine, disability medicine, general medicine, and mental health treatment. Break down silos between disciplines, and make sure that everybody is at least somewhat familiar with the full range of what they might see, and are working together as much as possible, or at least know who to go to if they are working with a patient who has a particular set of needs that they haven't seen before, or don't have a lot of familiarity with.
Thank you so much, Andrew, for that comment, and thank you to our panel today for the time that they have put in thinking about inclusion and access, and for coming today. Let's give them all a round.